Hi, I'm Dr. Ashley Fuller.
And I'm Dr. Meredith McClure.
And this is Labia Logic,
the podcast that's all vulva, no filter.
We're here to talk about all the stuff your doctor rushed through, the questions you've been too embarrassed to ask, and the sex ed that barely mentioned the vulva.
Because too many people are suffering in silence with painful sex, menopause misery, and vulvar issues no one talks about.
No shame, no stigma, just real talk, real answers, and the education you should have gotten in the first place.
Hello, and welcome back to Labia Logic. I'm Dr. Meredith McClure, and with me, as always, is Dr. Ashley Fuller. And we're here today to discuss vaginitis. And we're calling this the Discharge Chronicles, the usual suspects in the deep cuts.
Who doesn't love to come on a podcast and talk about discharge, right? And like pick up a podcast. Oh, this podcast is about discharge. This is what I want to listen to. So if you're here, it's awesome.
Hopefully you've not turned it off by now.
Right. All right. Well, we're excited to talk about this because this is super common. I mean, this is one of the most common things that people come into an outpatient GYN clinic with concerns about. We learn about this in residency, but I always think we don't learn enough about this in residency because it seems like this basic thing. Like people get BV or they get yeast and it's like no big deal. But the thing is it's actually a little bit more complicated than that. And so we wanted to kind of break down like the basics of bacterial vaginosis and yeast today. You know, mostly for patients, but also if you're a clinician and you're listening, I think there's a lot of tidbits here because I do think it's more complicated than the one lecture we got in residency on this. And it is so common. This is one of the, like I said, one of the most common reasons women come into a GYN clinic or even a primary care clinic. They can go to either saying that they have discharge or have some kind of symptom that is consistent with one of these infections.
So I don't know about you, Ashley, but I got into the vulva really because of vaginitis, because I had been in general practice and I was doing the things I was taught to try to help patients with these concerns. And a lot of them weren't getting better. And that's what led me down the path to really pursue and figure out what I could do better for patients.
It seems like a really simple thing, like you either have BV or yeast and you do one test and you take with one medication, but it's not that easy. And a lot of times people come back with recurrences or still having symptoms. And so I just think there's a lot more to these seemingly simple diagnoses. So yeah, I agree. I mean, and it's so frustrating as a clinician when patients come back and they're not better, right? Like we really want people to get better. Meredith and I talk every day. We really care. We really want patients to get better. And some of these things we take it to heart when people are not improving for sure.
Yeah. And I think when it comes to this concern and complaint, you really need to look at it in a big picture because so many people have vaginal discharge and they take it for face value and they go to their doctor, they get 10 or 15 minutes. There's a Q-tip put in the vagina and that's enough. And then you get information on that. And that's not always the right answer. You really need to look at the whole picture as far as, are you getting periods? Are you taking certain medications like birth control pills maybe that can impact how the environment of this part of your body is at that time? And it really makes a difference. You really have to ask these questions and to see kind of what the whole picture is showing you to understand why you have these symptoms.
Right. And these two infections, bacterial vaginosis and yeast, are super common. Most women will get a yeast infection at least once in their life. So 75% of women will have at least one yeast infection, but 40 to 45% will have two or more. And in our practices, we definitely see people who get recurrent yeast or kind of almost have chronic yeast sometimes. So super, super common. And then bacterial vaginosis, also very, very common. Most women will get bacterial vaginosis at some point in their lives. And especially in that age group, 14 to 49. So puberty to menopause or still premenopausal, definitely very, very common.
Yeah. And when we talk about recurrence, if you're thinking like, oh, am I recurrent? I don't know. We kind of consider if you have 3 or more in a year, that's a recurrent issue.
All right, let's talk about yeast first. So the common symptoms people have when they have yeast is that they feel itchy and they have like a cottage cheesy type discharge. It's usually clumpy. It kind of coats the walls of the vagina. They might notice it and they feel like they just want to scratch. They may even feel like they want to put their hands in their vagina and scratch because it can be inside the vagina and also can be on the vulva. But these are the most common symptoms of yeast.
Yeah. And sometimes if cottage cheese discharge isn't there, it could be just itching and burning. it doesn't, so can sometimes see it.
What I tell a lot of my patients is that, we always think this is like your typical yeast infection, like what we're talking about with the discharge, but definitely my postmenopausal patients, I sometimes see just skin infections of yeast. So like on the vulva, not in the vagina with the discharge. And so people often, if they just have itching on the outside, don't think, oh, it could be yeast if they don't have the discharge. So you can also have it there, which Meredith already mentioned this. But, I'm a big proponent of you should swab where the patient has symptoms. So if you have a patient come in and say they have vulvar itching, if you only put a swab inside the vagina, you may miss the whole diagnosis. So if a patient has itching on the vulva, please use your Q-tip or your swab that you're going to send off there. And you can also put it in the vagina, but don't miss the vulva.
You got to pay attention to that vulva. Is your problem inside? Is it outside? It's very important.
Yeah. I mean, I've seen patients that have had itching for 5 years and have been tested multiple times for yeast, and they just never were tested on the vulva. And in their first visit with me, I swab the vulva and I look under the microscope and I'm like, you have yeast. So I know. But you know what? I got to tell you, it's not hard. This is not that hard.
It's
Like
not.
someone shouldn't have to come see a specialist for this.
Vulvas can be hard, but that's what we're here to help with.
I
Yeah.
do a lot of really hard things, but when
Yeah.
those kind of things happen, I'm like, oh, like I'm so happy that I'm helping them and figure this out. But I also just think if we were swabbing in the right place, had we been taught to swab in the right place, right, then it would be a lot better. So
Yes. Yes.
So what yeast strains do we see the most? So the one that we see the most is Candida albicans. So this is the most common yeast that we see. Candida albicans, if you look under the microscope, which we'll talk about a little bit more in a minute, does usually make hyphae. So you can see little branches under the microscope. It can make buds too, but it definitely makes branches of hyphae.
Yeah. Kind of looks like tree branches with little berries almost sometimes.
Yeah, it's kind of cute.
Yeah.
And then Candida glabrata is the other second most common one we see. And this one never makes hyphae, it only makes buds. And it tends to be a lot harder to treat, and it's a little bit more controversial. So we'll talk about that a little bit more.
Yeah. They almost can look like little bowling pins under the microscope sometimes.
Yep. Or little shoes.
Oh, I like that one. I haven't heard that one. I like that.
I haven't heard the bowling pin one, but it's totally true. Yeah, see? And so I think it's important to talk about how we get these diagnosed. So oftentimes patients call into their physician's office and say, I have these symptoms, and they are just given fluconazole or diflucan over the phone without ever being seen. And so I get it. Like it's Friday, holiday weekend, or whatever it is. Like there are instances where I will treat without seeing someone, but I try not to do it because I do think we can miss diagnoses really commonly, especially if someone you've already treated them multiple times and they're still calling in with the symptoms. You need to do an exam, and patients, you should request an exam because someone needs to look and figure out what's going on. Because this is how people miss lichen sclerosis or miss other infections and are just giving fluconazole that's not actually doing anything.
Yeah.
So definitely do an exam. So Meredith and I are microbiology nerds.
You're more than me.
Yeah, I'm a big microbiology nerd. And we actually trained in residency. We had a microscope and we did tons of wet mounts. In fact, I don't even really remember sending that many things off, like swabs. I mean, we trained at a county hospital. We didn't have fancy stuff. You take a little swab. Now I put it in a little saline tube. It has a tiny little bit of saline in there. Bring it over to my microscope and I put it on a slide. I do 2 parts, one just in the saline and one with potassium hydroxide, because that helps me see yeast. And then I put a little cover slip on it and look under the microscope. And I have to tell you, it tells me so much. And I often can diagnose yeast just right there in the office from that.
I hang out with dermatologists, and what they do sometimes is they'll even kind of scrape at the skin and get the skin cells off and get on the microscope slide. And it's kind of interesting to watch them do that.
That's cool.
They use a microscope slide and they kind of scrape on the skin and scrape on another microscope slide.
Yeah, that's very cool. I've heard the dermatologists do that. It's a similar thing that, what we're doing. You can also do a yeast culture. So I find this to be somewhat underutilized. I use this quite a bit. It is cheap. This is not a PCR. So they basically take an agar plate and they, rub the swab on there and they wait for it to grow, usually like 7 days. And then they speciate whatever grows on there. So they will tell you exactly what grew, what species. Is it Candida albicans? Is it Candida glabrata? Is it some other, parapolosis, like some of these other strains that are a little bit more rare, which we definitely see. So that can be helpful. And then you also can add sensitivities to this. So if you have somebody who has recurrent yeast, I find this to be helpful because I can call up LabCorp and say, oh, that positive yeast, I'd like to actually add azole sensitivities to that to see if it's resistant or not.
Yeah, you sounded very professional and microbiological on that one
I
with your
did.
auger plates and
Oh, yeah.
everything.
Sorry.
Yeah, took me way back to college.
Yeah. Well, I mean, I just think it's so cool. I wish I could just grow 'em in my office, but yeah, whatever. So the culture is good. You also can do a PCR. So PCR, polymerase chain reaction. This is where they're basically going to take the swab, they're going to put it in some solutions, and they're going to look for specific codes on the DNA of this. And they're going to use that, and they sometimes use a nucleic acid amplification test. So they're going to amplify certain segments of code on these yeast to basically be highly sensitive at detecting them. And so these are way more expensive, but they're also pretty good. They are very sensitive, they're very specific. You can do a plain PCR test that basically is going to be just for Candida species or Candida glabrata and albicans, or you could do, we have these highly sensitive ones that are 6 species panels that can do lots of different types of them. I don't do those all that often. I think ultimately, like the yeast culture is just as good as that. And those ones are actually very, very expensive, depending on what insurance coverage is.
Yeah, and if you're ever on the fence and you can't really figure it out, that's when these are helpful, I think. But otherwise, sometimes it looks like the duck and talks like the duck, and
Right.
you look under the microscope and there's the duck, and you're like, oh my god, it's yeast.
It's yeast. Yes. Yes. If you see my yeast in a microscope, it's yeast. So that's always really nice in the office to be able to say that. So how we treat yeast, this is their first yeast infection. We I'll give them an option if they want a vaginal cream, which can be messy, but does treat the symptoms pretty quickly. So you could do a vaginal azole. So clotrimazole is my favorite. I will warn you about miconazole, which is monostat, which is the most common one you can buy it over the counter, that it often burns. And I see a lot of women who have allergic reactions or like irritation from miconazole. It
Yeah,
is
especially
irritating.
the one day it's like a bomb in there.
Yeah. So don't do it. I think you can find clotrimazole over the counter. It's not nearly as common, so you have to search for it in that yeast infection area of the drugstore, but you definitely can have your doctor prescribe it. There's also Terazole, things like that. And there's also oral fluconazole. So we use that a lot. I like fluconazole, but I always want to remind people that it interacts with a lot of medications, especially statins, sometimes antidepressants. So maybe it's a one-time dose. I'm not really all that worried about it, but if you're going to start taking it weekly, or if you're using multiple doses of it, you have to think about the other drugs it interacts with, the way it metabolizes, interferes with the way your body metabolizes other drugs. We sometimes will use longer regimens. Like if you see someone who's had these symptoms for years, I usually don't just give them one fluconazole. I'll give them 3 of them, and I have them take them every 3 days. Fluconazole has a pretty long half-life. So I should have them take them out like every couple of days. And then we talk about recurrences. If you have someone who's getting recurrent candidiasis, then we sometimes will have them take 1 fluconazole every week to suppress things.
And we're generally in this sense, we're talking about these albicans, or what I call like kind of your garden variety yeast. And if you're having a recurrence, you kind of have to look at a couple things. Look at the big picture. Is it an environmental thing? Like, do you have urinary incontinence? You're wearing pads all the time. It's wet down there all the time, and yeast really like that. That's something you can address to maybe try to be proactive with. Other things, you always want to make sure, like, you don't have diabetes.
Right. Absolutely.
We all have diagnosed people with diabetes with recurrent yeast in their vulva and their vagina. It happens because you will excrete sugar into your urine. And someone tell me what, so I think this is the best analogy, that literally it's like you're peeing molasses all over your vulva and vagina. And of course, yeast like that. And that causes an overgrowth, and then that leads to symptoms and problems. And then, of course, if your immune system is compromised in any way. So kind of looking at, do you have a condition that might compromise your immune system, be it like an infectious one or an autoimmune type of thing, maybe medicines you take that suppress your immune system, things that you normally would keep under wraps with a pretty intact immune system, you can't do so anymore. So you got to look at those type of things. And then there's just some people that are colonized with it, and it's not your fault. It's just you have baseline higher amounts of that living in your skin, and it doesn't take much for you to flip a switch and become symptomatic. And the fluconazole with these, garden variety yeast, it really just prevents you from recolonizing for 7 days if you're one of those people, which is why in our long-term course that we use with the therapies, we'll dose that once weekly because it kind of preventing to be recolonized. It's not necessarily eradicating it from you. So that's always something to discuss with patients, I think.
Yeah, I mean, I think some people are genetically more predisposed to getting yeast. So, I mean, definitely my patients who've had one of these rare yeasts, like Candida cruzi, something like that, they are more likely to get other rare yeasts. Don't you see that in your practice also? So there's some genetic component to it, or just the way their immune system is working there. So I sometimes will put patients on suppression longer than 6 months. We usually do like a 6 months weekly suppression, but I heard Jack Sobel, who is like the father of
The yeast god.
the yeast god, yes. I heard him say like he will put patients on this indefinitely. So, if you're going to have somebody on long-term fluconazole, I usually check LFTs at some point in that first year and just make sure that we're not bumping their liver enzymes because it can affect the liver, although it's not that common. There are some people that just, once they do great when they're on the suppression and you stop it and their yeast infections come back.
Hmm.
So
Yeah.
when we look at Candida albicans, like I even had a patient recently who had just battling yeast infections over and over again. We did a yeast culture, came back albicans, and I did a sensitivities, and her yeast was resistant to fluconazole. So we are seeing more azole resistant in our garden variety yeast. Another reason not to hand out fluconazole like candy, especially if you don't know what they have. So we are seeing more of that. And it is harder to treat when we have yeasts that are more resistant. So Candida glabrata has about a 40 to 60% rate of being resistant to azoles, so much more common. Whereas albicans is not as much, but definitely it does seem like it's increasing. So if we can't treat with an azole, then we're left with not as many options. So boric acid we can use. So usually buy this pre-made into capsules online, or you can compound it and put it in the vagina. You have to mention to patients it should never be taken orally because it's toxic if you take it orally. And so this is what it's doing, is reducing the pH so that the yeast cannot grow.
Yeah. Boric acid can kill the yeast. And we'll talk about bacterial vaginosis in a minute. And boric acid does not kill the bacteria.
Right. So boric acid can be helpful. I sometimes use nystatin in the vagina also, or on the vulva, especially if it's azole resistant. I think that can be helpful. I don't do it orally all that often. It causes a lot of GI symptoms. So I don't do that all that often. And then there are two other options for these more resistant yeast. There is an option to use a super long lasting azole. I'm going to say the name wrong, but it's Vivjoa or
Otis conisol.
thank you. I'll just console. So super cool idea. I think you take it more regularly at the first week, but then you just take it weekly, but it has a really long half-life. So the FDA actually has a bunch of restrictions on who can use this. You can't have any childbearing opportunities.
You have to be the golden goose. I always tell people you can have a uterus, you have to have your tubes tied. Like these medicines can cause birth defects. This medicine has a half-life. It lasts for a whole year. So if you popped a pill and you got pregnant in 6 months,
right,
you could have problems. So this is why you cannot have any reproductive potential.
Yeah, I think it's more of a theoretical risk. We haven't seen like that this medication causes birth defects, but azoles in general, we don't like to use orally for pregnancy. But yes, so not even an IUD, like you have to not have a uterus or have your tubes tied. So it's not very many people that can take that. I've actually only prescribed it once, I think. Or you could be postmenopausal, of course. And then abrexafungerb or Brexafem was a different type of antifungal that was great. It was on the market for about 2 years. And then they were really looking at these more complicated yeasts. But the company who made it, Synexis, they sold the drug to GlaxoSmithKline. And then at some point, there was contamination in their manufacturing line. So they've had to revamp their whole manufacturing line to make it more pure. And it's been a year and a half, maybe even longer than that. And I don't know what's happening with it. I've done clinical trials on this medication, and I think it's a really great thing to have in our toolbox. And I'm really sad we don't have it. And I don't know if it's coming back. When I talk to GSK, they don't know either, like the people that work there. So it's really up in the air right now whether that's going to come back.
It was a good one.
Yeah, it was. It was nice just to have another option, especially it's an oral medication that you just take 2 pills twice in one day, like 2 different times in one day. And people tend to get a fair amount of GI side effects from it, but for the most part, people did pretty well on it. All right. Is there anything else we should say about yeast?
I don't think so. I think we hit that one pretty hard.
Yeah, I think we did. The only thing I was going to add to when you talk about diabetes is also medications that you're on for diabetes can increase it.
Oh, God. How did I forget that?
We can't not talk about Jardiance.
It's the worst. If you take that medicine and you see the TV commercial of the lady dancing in the street, she's dancing because she has a raging yeast infection on her vulva and in her vagina because she can't sit still. This medicine is used for diabetes, but also for even like cardiovascular disease kind of prevention. And it literally makes you, I mean, we talk about peeing molasses. I mean, this is like buckets and concentration levels that are insane. So the side effects when they run it off on the TV commercial, like you're going to die and all this stuff, it just says yeast infections, and it's not nothing to blow off. So if you take that medicine and you're having these issues, please seek help.
Yes. Yes. Because you could be having lots of recurrent yeast.
Oh, yeah. Some of the worst yeast infections I've ever seen.
So now we are going to move on to bacterial vaginosis. So bacterial vaginosis is super, super common, like we already discussed. And I think that one of the questions, yeast infections are not a sexually transmitted infection, although, yeast can be present on people's skin and things like that. There's this question now, especially since there was a recent study that came out about treating male partners, is bacterial vaginosis like a sexually transmitted infection? And I think it's important to look back at like, what is bacterial vaginosis? It's not one bacteria that's making you have this. It is a microbiological state. I'm geeking out on my microbiology again, but it really is like your microbiome is off. And so you have too many types of bacteria that are these anaerobic bacteria that basically give you this odor and increase the pH. So this is Gardnerella, Mobiluncus, Provotella. There's actually a bunch of them. So it's not just one. There used to be this idea that if you had Gardnerella vaginalis, you had BV. That's not the whole case. So we're going to talk about this more and how we test for this, but really it's a microbiological state of being. And so I always say when your biome is off, then that's when you get this. So we think about things that disrupt your microbiome. So a new sexual partner, multiple sexual partners, douching, taking a certain like an antibiotic might make things off because it may kill some good bacteria, things like that. The symptoms are odor and discharge. So usually a thin white discharge and usually a very fishy odor. It is an osis, not an itis. So it's not inflammatory. So when we look under the microscope on this, we generally see these things called clue cells. Clue cells are cells that just have a lot of bacteria stuck to them. They look like glitter cells almost because they have all this extra bacteria on them. But I don't see a lot of white blood cells. I do for yeast because yeast is super inflammatory and white blood cells means inflammation. This is not inflammatory. So while I definitely have some patients that feel they sometimes have burning with BV, and that could be from the type of bacteria that is creating their microbiological state, it generally does not very associated with pain. Wouldn't you say, Meredith?
I agree. It's definitely an osis. It's like, the HOA of your vagina let the wrong tenants move in and the neighborhood is kind of pissed, but in a way that creates discharge and odor.
Right. So there's some intruders that shouldn't be there,
Yeah.
set up camp.
But so they've kind of lived there all along. It's just they've,
True.
maybe they had a party and left the speakers on too loud, and that's the problem. But they've lived there for 20 years.
Sure. I do have, like I said, some patients that do feel like they get burning from this. So I don't want to say it's not possible, but it's just not the common thing. We talked about triggers, newer multiple sex partners, not using condoms, douching. Obviously, don't do that. Smoking increases the risk. Your period increases this. We get your period or pH goes up. The pH on this is a high pH. So usually the pH is greater than 4.5 on this, whereas yeast is usually a lower pH, like a 4, 3.5, 4. IUDs may have some association. Meredith, what do you think about that?
Clinically, I kind of see some of this. There's, of course, we have the kind of essentially two types of IUDs. You got the copper, and I know there's some evidence with the copper, but I think even with these leave-in agestral or these progestin IUDs that you don't really get a period, you don't see anything necessarily coming out of your vagina on the blood front. You do have some blood that is up at the top of your vagina, and you have these little strings hanging out of your cervix. And could that kind of create and coat, in an environment kind of essential? We'll talk about the biofilm because, there's a thought that with bacterial vaginosis that there's kind of the dysbiosis microbiome is off camp, but then there's also this biofilm camp. And is it both? Is it one or the other? The jury's still out. We're trying to figure all this stuff out. But the biofilm is this kind of sticky substance. You don't know it's there, but it's kind of like a thing that bacteria can kind of adhere to. And it's almost like a food substance. but are these strings in the blood that's kind of up there where we know the pH is a little higher, creating something there for more bacteria to stick to. And then maybe you have something else like semen that comes in that's also basic, or anything just flips that switch and now you're symptomatic. Again, these are things that kind of live there all the time. It's just how much is coming into play and what's up and what's down, and when those symptoms will hit, and all of a sudden you're like, God, I really have this odor all of a sudden.
Right.
And some people, I think I'm asking people like, well, when do you notice it? And some people, it's, oh, it's after my period, or,
Right.
it's after I have sex every time. And to really kind of like figuring out triggers as well is important.
This can sometimes be hard to treat. And I think what we're saying is because some of these bacteria live there all the time, it's hard sometimes to get that microbiome back to like that balance. And so recurrence is actually very, very frequent for BV. I think it's important to talk about how we diagnose BV because I see a lot of false positive BV. I'm sure you do also. So because I look under the microscope, I always do a little Amsel's criteria. So this is also geeking out, but basically to have Amsel's criteria, you have to have 3 of the 4. So a thin white discharge, pH greater than 4.5, clue cells. I think it's greater than 20% clue cells under the microscope. And then you put your potassium hydroxide on the discharge and you should have a fishy or a mean odor. And that's a positive whiff test.
And yeah, we get to do the whiff test.
Yes, we do the whiff test. If you have 3 out of the 4 of those, then you can say it's BV. It's not super sensitive. I mean, definitely, I think you could miss it. But I think that if it's there, if you see these things, it's pretty specific that like, yes, this is definitely BV. The one that drives me crazy is the Affirm test. So the Affirm is a DNA probe. It's a 3-part. It tests for Candida species, so multiple different candidas. It tests for Gardnerella vaginalis only, and it tests for Trichomonas. This is super common. I don't know if in your part of the country you see this.
Every day of my life. Every
Yes, like
day.
why do we use this test? Because here's the deal. Just having Gardnerella does not mean you have BV. So there's about a 20 to 40% false positive rate on this test because it's not very specific. If it says it's positive for Gardnerella, it doesn't necessarily mean you have BV. It's testing for one bacteria. And so I actually really like these multiplex nucleic acid amplification tests. We have like Aptima swabs. I don't know which ones you guys use, or New swabs is the one. It looks at how much good bacteria you have and how much bad bacteria you have, and it gives you a scale of how likely it is you have BV. So sometimes it comes like 0 to 1, or it'll be like 2 to 4. 0 to 1 means you don't have it. 2 to 4 is like kind of it's indeterminate, and then 5, 6 you definitely have it. I find that to be much more accurate, and the specificity and sensitivity is much higher in that than using the Affirm.
Mm-hmm. Agree.
So I geek out on this because the thing is that I sometimes see patients that this is what starts them down this path of terrible vaginal symptoms because they keep treating their BV that they don't really have with Flagyl and metronidazole, and then all of a sudden they're having pain, and it's just. I always think if we hadn't started with that Affirm, maybe we wouldn't be here.
Yeah. Yeah. It could be a vicious cycle. And the patients, land with us, and I look at them and say, but you're not better. And so what are we chasing? This is giving you information. And sometimes these are innocent bystanders that they're catching on these swabs, and they're not really the problem. Again, you got to look at the big picture. So one other thing I think that comes up kind of often is you get your pap smear.
Oh yeah, I'm glad you mentioned this.
And the pathologists, I mean, I love pathologists, love y'all, but they like to sometimes put in this little side note, and now patients can see their records when they get their test results, and they call and they say, they saw some yeast, or they saw a shift in my flora, which means just your bacteria that live down there, your microbiome. But there is a shift noted in my flora suggestive of bacterial vaginosis. And so many people get treated for that. When really, if you're not having symptoms, again, you don't have bacterial vaginosis. If you don't have odor, if you don't have the discharge or like the irritation, anything like we're talking about, you don't got BV. I mean, that just the shift and the suggestive, that's just them seeing your microbiome.
Right.
And it just matters if you're symptomatic. And then they get tested, and then they'll get retested to see if it's gone. And again, retesting to see if it's gone is not the way to go. It's costs you money. It costs you stress and anxiety if it's not gone.
right? And maybe messing up your microbiome. Like if things are good, if it's not
Especially
broken, don't fix it.
especially metronidazole or clindamycin. Good God, we use clindamycin. That can give people some really serious gastrointestinal stuff.
Right,
So like we gotta be careful in the over treating and really just ask the questions. How are
right,
you feeling?
right.
How's the vagina?
Yeah, the pap test is not my favorite because it's really hard to convince a patient they don't need treatment. They see this and they're like, "Oh," especially if a patient has other symptoms. It may, and so I always tell patients the CDC actually doesn't recommend that you treat based on a pap smear. If it comes up on a pap smear, you could come in and get the other tests we've talked about, like a PCR or yeast culture or something like that. If it's because they do this for yeast also, they'll say like Candida species noted. But again, if they don't having symptoms, I usually tell them not to do anything about it. So it's kind of like more information than we asked for kind of situation.
It's hard sometimes to talk to patients about that because they see this and they think, oh my God, I caught something. This is really bad. I need to get tested for all these other things. And this is just normal stuff that lives there all the time. It's just they saw it when they were doing your pap.
Yeah. So how we treat BV. So once we diagnose it, we are going to do metronidazole antibiotic. You can do it orally as flagyl, or you can do it vaginally. Metrogel, that's 5 nights in the vagina, or you can do a clindamycin cream. You can do clindamycin oral, but what we talked about, what Meredith mentioned, is that actually clindamycin orally is one of the ones that can increase your risk of C. diff, which is a GI infection that you do not want.
No
No.
hospitalizations.
Yeah. And then it used to be this thing that you couldn't drink alcohol with metronidazole, and I think that's gone the wayside now. So you can.
It was always a good excuse if you were trying to hide the fact you were pregnant. You're like, oh God, I'm taking Flagyl. I can't. So no one knows I'm pregnant.
BV has a high recurrence rate. Sometimes I'll have patients that just use kind of a maintenance. So Metrogel once or twice a week, or I like to do it sometimes after triggers. So after sex or things like that, if they feel like that's what's triggering them. I think it's worth talking about the study that came out just a couple months ago where they actually treated male partners. So they made the male partner clindamycin cream on the penis. And then also I think oral Flagyl. Is that correct?
No, yeah, I
Yeah.
believe so.
They actually saw it reduce the recurrence rate by half. So it went from like a 60% recurrence rate just in the 12 weeks that they were following these patients down to a 30% recurrence rate. But I think it's important to see that like there's still a 30% recurrence rate. So a third of these people, even when we treat the male partner, are going to have a recurrence. So this is not the whole story. It definitely improves it. And I think it's a great thing, but I definitely think it's not the whole story. And I'm hoping that we get a better understanding with the research that's going on about the microbiome of what is really happening here. I'm hoping that we get better evidence of how we can restore the normal microbiome in a way that's not a bunch of antibiotics and things like that.
Yeah. And there's people who aren't having sex with men or not having sex at all and they get recurrent BV. So just goes to show you it's not just a sexually transmitted thing.
Absolutely. Probiotics are a little bit of a rabbit hole that we could go down, but I definitely want to mention them. There is not any real good evidence about probiotics working, but I think from a microbiological place of thinking, it makes sense that if we could reestablish a normal microbiome by using probiotics, that it would help. So I do sometimes have patients use certain probiotics to try to like reestablish the normal healthy microbiome, especially after we treat with antibiotics, so that we are kind of seeding things with good bacteria instead of having overgrowth of bad bacteria. So there are some good ones on the market now. The bacteria that we really want is Lactobacillus crispatus. That's like one of the most protective. And there are some that are vaginal. I like the vaginal probiotics better because I think orally, I mean, I know it can get there a little bit, but it just feels like vaginal. You put it where you want it. It feels better. How do you feel about probiotics, Meredith?
I'm pretty much the same way. And I think there's road to hoe here to figuring this out. I think we've come pretty far with GI stuff when it comes to probiotics, and vagina still needs a little work.
There's some definite good data about using probiotics for GI issues. I think we just need to understand this better. I definitely see patients, and I know you do too, who do these send-off microbiome tests. So I just wanted to mention this. There are some companies where you can put a swab in your vagina and send it off, and they will give you your whole microbiome. And as a microbiology geek, I think it's fascinating. But I will say that some of the things that's happening, I think, at least in our industry, I don't know if it's happening in others, is that like our technology and our ability to generate data is outpacing our knowledge of what to do with that data. And I think this is one of those times. I do find these to be sometimes helpful, but you're often left with, okay, well, this is what's happening with your microbiome. Now, what do we do?
Yeah, you really need to look also at the whole picture. Just another shout out to, I think we all know how much we love vaginal estrogen. I would honestly, if you're, postpartum, you're on a birth control pill, you're going through perimenopause, menopause, you're having some change in your vaginal odor that's kind of smelling a little fishy, it's always worth a shot to put a little vaginal estrogen in there, which is going to feed those good bacteria and bring your pH down. And that's something always worth a shot and never would hurt anything.
We love vaginal estrogen.
Did you want to talk about a little trick?
Yeah, we talk about trichomonas. I was thinking about it just because it's OmniAffirm, my favorite swab test. So trichomonas, the CDC recommends you do that PCR. That's the best way to diagnose that. You can see it under the microscope. Actually, also one of my favorite things to look at under the microscope. They are single cell flagellated organisms. And so they move around with this little flagella that moves them around.
Just like that. That's exactly what they do.
Yeah, they kind of go like this.
Yeah.
Sorry about my dancing. They're very interesting to watch. But yes, trichomonas is a sexually transmitted infection. It causes irritation and can cause a little irritation along the vaginal mucosa and on the cervix. Lots of kind of more thick, frothy discharge because it definitely is very inflammatory. To treat trichomonas, it's going to be metronidazole or flagyl also. It used to be a one-time dose. The CDC's changed it to a twice a day for 7 days, similar to the way you treat bacterial vaginosis.
And you treat your partner.
And yes, you should treat the partner. Occasionally, we will get some metronidazole flagyl resistant trichomonas. Usually, have to send that to the CDC, and they have to do all this testing and then let you know. I haven't seen that since residency, but it's terrible when it happens.
Yes, that's a hard one.
The take home here is that you could see this was our basic vaginitis and we went to the complicated parts of this. Maybe it's just the lens we see patients through because we don't see a lot of definitely have patients that see me for other things and just get a yeast infection and we treat it and we move on with our lives. But a lot of what Meredith and I see is complicated stuff that probably started out not that complicated. So I think these things can start out basic, but they get complicated pretty easily, as you can hear from this short podcast.
Agree. Yeah.
Yeah. So if you're a clinician and you don't have a microscope in your office, I do recommend trying to get a microscope. I know a lot of places won't let you have them anymore. They want the central lab to do them, but you learn so much from looking at a microscope at Discharge. It just gives you so much information and it's so nice to get it right in that moment.
Yeah, it's even fun to let the patients look at it.
Yeah, I definitely love some of my patients come back and you want to see your yeast? And they get very excited. So hopefully this wasn't boring and hopefully you enjoyed this microbiology geek talking about vaginitis. But we appreciate you being here. As always, let us know if there's things you want us to talk about. Next time on this, we're going to talk about complicated vaginitis. So the deep cuts. So we were talking about desquamative inflammatory vaginitis. So we were going to talk about cytolytic vaginosis. And maybe we'll talk about some of the recurrent stuff too that we've kind of mentioned here. But we're going to talk about the more complicated stuff because it gets even more complicated than this, if you can believe it. Sure does. Sure does. Thanks for joining us for this episode of Labia Logic.
We get it. Sharing a podcast like this might feel a little taboo, but we're here to break down those barriers. Labia Logic's all about empowerment, not embarrassment.
If you found this episode helpful, we hope you share it with others who could use a little Labia Logic in their lives. Can't we all? You can find us on all major podcast platforms and connect with us on Instagram at labia_logic.
From our lips to yours.
Viva la vulva!